This is session 14, Acuity Leveling. Well, let me introduce Reid. First of all, the disclosure for each session, the presenter has indicated that his presentation will not include any discussion, any commercial products or services, and will not include any discussion of off-label and or investigational uses of any product or services, and will not include trade names. Let me introduce Reid Reyman. Reid Reyman is the Executive Vice President of Regional Development for Altru Health System in Grand Forks. Welcome, Reid. Thank you. We look forward to hearing from you.
Delay. Hey, I have a very important topic I want to talk to you about today called acuity leveling. And I know that the nursing staff understand what acuity leveling is from their standpoint. Take the diagnosis and the severity level of their patients and then assign nursing staff to it, staffing. I'm going to take it to a different level today and have a little visit about acuity leveling. It's a defined process that uses quality data, patient data, and facility capabilities to assign a severity of illness patient acuity score that can be used to create equitable and quantifiable hospital placements. Now, I know that's a lot, but that's the goal for the overall presentation that I have today. And I think that once we work through it, you're going to have to bear with me. We're going to be using some different terms today that maybe you haven't associated with transfers and discharges and keeping patients locally. But we're going to define acuity leveling and then work a little bit with the case mix index today. So acuity leveling can be used both internally to assure proper care assignment and externally to assure proper transfer of care facility. So it's important to understand how patient populations differ between hospitals when looking at quality data. The severity of illness or how sick patients are at each hospital will have some impact on overall patient outcomes. So severity of illness is also called acuity. Now, we all know that we have different levels of acuity at our hospitals, but how do we measure that? And there's a financial indicator that a lot of people use, but they don't use it a lot of times to establish transfer discharges, strategies around how to take care of patients. And so severity of illness is called acuity, but a standard measure to compare patient severity of illness between hospitals is called the case mix index. Now, a lot of times case mix index is used as a financial indicator, but I want to explain that a little bit. Bear with me for a while. I'm going to jump into case mix index, do a little bit of education on it only because this does all tie together when it comes to discharges and transfers. So the case mix index has historically been used to calculate adjusted average cost per patient for a given hospital relative to the adjusted average cost for other hospitals by dividing the average cost per patient day by the hospital's calculated CMI. Now that's a lot. If there was a slide, it'd be a little bit easier, but the adjusted average cost per patient would reflect the charges reported for the types of cases treated in that year. So let me jump into an example for you and start tying this together. So example, if hospital A has an average cost of per patient of $1,000 and a CMI of 0.8. So remember, the CMI is your acuity level, so 0.8. Their adjusted cost per patient for $1,000, 0.8 into that $1,000 is $1,250. So your cost goes up. So the lower your acuity level, the higher your cost per day. So likewise, if hospital B has an average cost per patient of $1,500 and a CMI of 1.25 or a higher acuity level, because anything above 1, below 1, that's kind of your average. It's a good way to think about it. Cost per patient day would be $1,200. So the higher the acuity level of patient that you can take care of, the less cost you're going to incur. So that's the financial savings part. But that also is what we all want to do is take care of the sickest patients we can locally. So therefore, if a hospital has a CMI greater than 1, their adjusted cost per patient or per day would be lowered. And conversely, if a hospital has a CMI less than 1, their costs would be higher. So the CMI of a facility reflects the diversity and clinical complexity of the patients and the associated resources utilized in the care of those patients. So let me say that again. The CMI of a facility reflects the diversity and clinical complexity of the patients and the associated resources utilized in the care of those patients. So the one thing that we need to do in all hospitals, especially in the rural hospitals, is we need to try to increase our CMI. We need to try to increase our complexity of the patients that we serve and the severity. And you say, well, of course we do. That's what we always try to do. But at the same time, we need to develop that regionally, and we need to develop that with our care partners across the region, because as a PPS hospital, we want to take care of the highest acuity level we can also. And by comparing our patient data across similar areas, and by comparing our CMIs and looking at the CMI, we can start gauging different complexities, and we can start gauging how those patients are transferred in and how those patients are transferred out. Now, to start with the CMI, there's some simple things that we need to do locally. I'm going to give an example. I could have three hospitals and three rural hospitals from three geographic areas that are very similar. And I know if you've seen one critical access, you've seen one, but there's similar populations, similar diagnosis, similar staffing models, all those things, same size. And yet, if you compare the CMI across those hospitals, the case mix index, you're going to see some disparate. Often you'll see a lot of disparities. And as simple as a 0.1 or a 1.2 to a 1.3 is a major difference in the types of patients that you're able to serve locally. And see, a lot of that though is determined by your clinical documentation. So we'll get into this, just the weeds a little bit on CMI. It has to do with clinical documentation. You have to make sure that you're documenting all the care that needs to be documented. And this ties right into most of our quality indicators that we use as well. Comes into documentation. A lot of times the reason you fall out of quality is because of your lack of documentation. So the first thing you do is you got to check your clinical documentation and find out if you are maximizing your CMI. And then once you're maximizing your CMI, we can move to the next step. Okay. So to start, CMI data is compared and shared. So I don't know if we're doing that across our divisions, but we need to do that across the state with our partners, with the people that we work with. We need to start sharing our complex data, our CMI data. We need to share the acuity level that we're taking care of at each place so we can compare and contrast and find out why is another hospital with a similar staffing model, similar diagnosis, all those, why is their case mix index a little bit higher? Because here's what happens. The more acute patients that you take care of, the higher your case mix index. The higher your case mix index, the lower your cost per day is. The lower your cost per day is, which then allows you to reinvest, raises revenue, and gets it back up. So ultimately, you want to take care of the highest acuity patients that you can possibly take care of locally. Now, how does this tie in together? The way that we can tie this together to start is once we can maximize, we figure out if you're maximizing your CMI, then we're able to look at your referral patterns, what you're referring out. And if you've pulled your case mix and you've pulled your referrals and you've looked, why am I shipping out a 0.8 CMI patient? Why am I shipping out somebody that's a 0.9? Why on this shift this night, or when this physician's on or this mid-level's on, why am I keeping the 1.1s and the 1.25s or the 1.5s, and on other days we're not? So there's a combination there of clinical documentation, of course, that's important, but it's also important to look at the acuity level of the patients that you're keeping. If you want to establish a step-down ICU, if you want to increase your revenue, your bottom line, you have to increase your acuity levels. You have to do that across the board. So like I said, that's where you start. And we can start by comparing and contrasting those. And that's one way to do it. Secondly, strategies are developed between facilities to increase the CMI at each facility. Well, how do you do that? You say I have limited resources at a critical access hospital. I don't have a step-down ICU. I don't have an ICU. Or how do I increase? I only have 3 or 4 instances of care that can help increase that. What you need to do is partner with another critical access hospital, your local PPS, and different things. The only way that you could increase, a good example is, say that you want to do detox, because unfortunately, a lot of our step down ICUs in rural areas are, we do a lot of detox. Now with detox, there are certain protocols, there are certain standards of care, there's also certain medications, there's pharmacological things that a lot of small hospitals don't carry because of the cost or the price, and because you don't do it that often. However, you can find ways to partner. What are your strategies? Because you have to find ways to do that. Well, we look back, we only have 4 patients we could have detoxed last year. We need to keep our competencies, we need to detox 12. Well, then can we set up 8 simulations with our local tertiary facility where my staff can stay sharp and do what we need to do? A lot of us do that with our OB patients. A lot of this do that with a lot of other clinical activities. But when I start talking CMI, I lose the clinical side. The clinical people turn off because they think that's a financial measure. But what it does is it helps us to look at the acuity. What is your actual acuity that you're handling in your hospital? And don't just look at your overall CMI. What is your acuity level at nights? Are you transferring people at nights because your staff doesn't deal with that, or that it's uncomfortable, or we don't have those people on call? What's your strategy around that? What's your acuity level on the weekends? What's your acuity level, you know, just at different times of the year, over the holidays? When is it the highest? When is the lowest? Are you tracking that? Are you looking at that? Are you looking at your CMI? Are you making sure it's accurate? And then you can start building services that your community needs off of that. Because the only way that you're going to increase, because we get stuck in a rut, we get stuck in that pattern that, well, this is what we do and this is all we ever do. And we only have this much staff, or we only have this much. Well, if you keep lowering your acuity level, your CMI keeps going down, you go below that one level, then your cost per day goes up, and you just keep cycling down. So you have to find a way to stay relevant. You have to figure out a way to cycle back up. Sometimes it's as easy as, first of all, like I said, checking that clinical documentation. You're probably doing more than you think you're doing. You haven't changed for years. You're not looking at all those opportunities. You're not taking credit for all the things that your staff is actually doing. You're not charging at the highest levels. You're not looking through all that complexity that's actually happening on your floor. You're not doing that. You get into a standardization. I don't want to say a rut, but you get into a comfort zone, and that's where your staff stays. But we all know that we're looking for payers, we're looking for resources, we're looking ways to support each other. And let's start with the CMI. Let's get this acuity moving up higher and higher, and then work together to do that. So how do we work together? Well, we can work together clinically. We can provide training. We can provide education. We can do that. But ultimately, the goal is to get to the place where transferring facilities can develop an acuity leveling tool based specifically on quality and care data that ensures the patients receive the highest level of care locally prior to transfer. So in other words, if we're getting a transfer from a specific critical access hospital, and this happens a lot, it's nights, it's weekends, it's holidays, we get somebody in that maybe needs a 24 to 48 hour stay with us, but probably doesn't need to stay that other 2 or 3 days just to level out those medications. Or we end up with transfers in that sit in the ED for 18 hours and just get fluids, and then they go back. Or we get a transfer in that we put on the floor based on the documentation that we received or lack of documentation, or we duplicate tests, or we're doing things and we find out that person should have been served back. But what we do is we don't communicate that back. But if we knew that, I know Pete's there, if someone came in from Northwood and they had an basic acuity leveling score of 1.4 or 1.2, whatever it is, say 1.2, and we start getting patients in that are in that 0.8 range, we pick up the phone, we call Pete, we have conversations, we say, what's happening? There seems to be some discomfort with your staff because they're sending things they haven't sent in the past. We start communicating back and forth, we figure out why, and we could work with that. Or if Pete calls and says, hey, we want to keep more patients in my ICU. I want to get a little more established here. How can you help me? Then that's that, quid pro quo on our end, but it's more we want to reach out, because the last thing the tertiary facility wants to do is fill up with low acuity patients. And then when the high acuity show up, we don't have the bed space, or they go on. Now, here's what happens too with low acuity, guys. 2 things happen that are very, very important. Not only do you lose financially, but the second thing that happens when you have low acuity patients is your engagement scores go down. Your staff wants to take care of the sickest of the sick. Your staff does not want to just be a place where people show up, get fluids, and transfer. they want to get excited to come to work. They may not at first want to keep those 4 detox patients a year because they're nervous and they haven't done it very often. They only do 1 a month. But if you provide them the opportunity and the education and you work with your local tertiary facility to enhance that program, you're going to see a significant increase in your patient engagement, your physician engagement, your provider engagement, and you're going to get a higher acuity level locally, which is what the patients in the community wants. So receiving hospitals are educated on the highest level of acuity each transferring hospital can provide to ensure the highest level of patient quality and satisfaction. Now, why would we need to know that? Because one of the things we're working on here is we know that Pete's done all he can to take care of his patient Northwood. He's maxed out. He doesn't have the necessary, maybe he needs additional diagnostic equipment, or it's a type of medication, or it's a service that he just can't provide. He's tried and that's the level he's topped. But we know after we get him here and we work with that patient clinically for 24 to 48 hours and they're stable and we're just monitoring the medication, how do we get that patient back? So that the last 2 days or 3 days, they're not sitting in a large tertiary facility when they can be back over with Pete, and Pete can be monitoring and helping and educating and doing that. And then we're still maximizing his acuity level, and we're still maximizing ours by getting patients back as quickly as we can. But we need to communicate back and forth on that, and we need to know what those levels are, and we need to know the maximum acuity that each facility is comfortable in handling, but can handle, and then not really just comfortable, because I think we're all comfortable now, but how much more we can maximize that. So receiving hospitals also don't duplicate services. We provide the appropriate level of care, and we're aware of transferring hospitals' patient acuity levels, allowing for appropriate discharge planning, which I just talked about. So one of the things we started to do at Altru is we allow the minute that, if you haven't had this call, you should. If you have any patient that gets transferred in from your hospital to Altru, the discharge planning meeting, of course, happens the first day that the patient's here. Our discharge planning team calls your social worker, your nurse, whoever it may be, to get that person on the discharge planning committee. So we can start doing that co-planning immediately to get that person back to your highest level of care as soon as possible. Now, I kind of went through this quickly because we couldn't get on, and this is probably more of a 2-3 hour presentation. I've got a lot more information, but the bottom line is more care locally for the patient, equitable and quantifiable quality data, because if we're working on acuity levels back and forth, and we're working on CMI, and we're working on the clinical documentation, we're also sharing that quantifiable data back and forth, which I think is very, very important. Less duplication of services, which means lower costs for the patient, lower costs for the hospital. I think contrary to what is believed in rural hospitals, I used to believe the same thing, is that the big hospitals just bring in and want to duplicate everything that's happened. Well, we all know that whoever bills a lot of those things first gets the reimbursement. And so that's not what any physicians want to do. They want to get the most information, the highest quality communication. Dr. McKinnon has educated me on this very well. When that patient lands in front of you, you want to have the best documentation that you can have. You want to have the best diagnostics possible that the other facility can do. And then you just want to add just a little bit what you need to get that patient the finest care they can get as quickly as they can get it. And then we want to get that patient back. And I think that's important. We need to know that. That's cost savings for hospitals and patients. Remember, the higher your CMI, the lower your costs are going to be. The more you're going to maximize your services, the more you're going to maximize your staffing, the more your engagement scores are going to go up, the more that your staff's going to be excited to come to work, and the more services you're going to be able to provide for your community. And then better communication between transferring and receiving facilities. So I apologize for not being able to jump on. I was trying, I was back and forth. I'm not a huge visual fan here, but thank you for being able to hook me back in. I went through that kind of quick. I see there's a few things in the chat, but do we have any questions?
Reed, there looks like there's kind of a question from Dr. David Schmitz. What if we looked at the diagnosis codes most commonly associated with those potentially unnecessary transfers and correlate that to clinical skills and training of providers. I think us in Northwood would love to be a partner with Altru if you want to do a, maybe it's too overwhelming to try to think for Altru to do it in the entire region. Maybe you want to reach out to the hospitals in the region to see if anybody would be your guinea pig, if you will, to work with Altru. So any thoughts on Dr. Schmitz's question?
Yeah, no. Hey, Dr. Schmitz, good to hear from you. And yeah, I think he's exactly right. I mean, diagnosis codes, this is where we need clinical, and this is what happens a lot of time, to Dr. Schmidt's point, is when I start talking CMI or we start talking about acuity leveling, then right away you hear, well, acuity leveling, that's something that nursing staff needs to do to figure out how they staff, or that's a financial measure. And like I said earlier, I don't get the clinical input that we need. And I think Dr. Schmitz, we visited a lot, and David, I think you're exactly right. Diagnosis codes would be great. We still have to work our way through some of the, way through some of the HIPAA things and things like that. And Pete, to your point, with so many of those hospitals tied into our EMR, tied into Epic, and with that slicer dicer and the different things, there should be a way that we should be able to work through some of these issues fairly quickly. And yeah, we would love to get this start. Some of the things I'm talking about, I don't think are much different than if you're in a CIN already or in an ACO that they're already working on. And so I think that some of these, this is very similar to some of the other programs that people are using. A lot of them use it to track quality data, but they're not using it to track, like I said, that actually filters all the way down to actual clinical work hands-on with the patient.
Well, Reed, if I can just follow up with a quick comment. Kylie had given me speaker privileges just as we were kind of talking about a study that was done in Colorado. Excuse the younger picture of myself here, but it was interesting. A professor down at University of Colorado, interested in scope of practice for family doctors, did a study looking at the transfers from critical access hospitals to tertiary centers, and was able to run those diagnostic codes, and then kind of backpedaled that to, are there specific procedures that family physicians in rural areas could be trained to do that would have prevented the transfers? So for example, nasopharyngoscopy, or there's just some things that some family docs might do, some might not do, and could potentially be either ongoing continual medical education or put into our residency programs to inform. And I've always thought that was a great study. I just looked for it. I can't find it in the literature, so I reached out to him. I'm not sure it was published. I'm not sure it had enough numbers. That would be fascinating to do in North Dakota, because every state's different. Their needs are different. And again, Matt had made a comment that, could we use this to support nurse practitioner residencies or PA enhancement of skill sets along with nursing. So if you're interested in that, Reed, maybe between you, Matt, and I, we could, I work for the University of North Dakota, and part of my day job is to try to construct these and get them through IRB, which would hopefully, we could replicate the study that was done in Colorado to a certain extent, and maybe even do it in 2 states. So these are the sorts of things that that I'm here for. So anyways, I'll stop, and you've got my email, I think. So.
Yeah, Dr. Schmitz, I think it would be nice for residency program is to have, or even for someone that goes in and does, the nurse practitioners or any of the providers that go in and do some of their education. Wouldn't it be nice to say one of your goals is to increase the case mix index of the local hospital, and just and even to get them thinking about that and thinking about acuity and what we can do. But also, we bump up against there's a lot of cultural things we bump up against too. When I was, I hear this a lot. Every hospital I've been a CEO in, and say, well, we don't do that here, or that's not what we do, or we just can't do that. And yet the nurses, and yet when we talk about other things, the nurses are usually very well trained. They just haven't laid hands on those types of things for a while, and they just need some refreshing, and they just need some confidence back. And then the providers the same way. And then it's engaging those physicians and those providers to help train and educate and be involved in that day to day to help increase that acuity level. Because like I said, everybody kind of gets into their comfort zone, and we need to push people out of that so we can increase those levels and care for more of those people locally and at home. Are there any other questions? I know I'm bumping up against the time, but
Any other questions? Anybody? Great job, Reed. Thank you very much for your time and effort put forward in the presentation. Any last questions? You want to enter them in the chat box? I'll read them. We got a late start, so I think we can steal a couple of minutes of our break. Any last questions for Reed?
well, thanks for hanging in there with me, Pete.